Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário in Porto. Today, I will be discussing two challenging lupus cases with Professors Andrea Doria and Sandra Navarra from the Lupus Academy Steering Committee. Andrea and Sandra, welcome and thank you so much for joining us today.
Thank you.
Thank you.
Let's just dive into the first case. If you want to see images, go to the show notes for links. So the first case, this is a young woman, that she was born in 1991, diagnosed with juvenile lupus in 2005 when she was 14 years old. She presented with fever, pleuritis, polyarthritis, and low-grade proteinuria between 0.3 and 0.5 grams a day. Her ANA were positive, anti-dsDNA were pretty high, and anti-U1 RNP and anti-SMIP antibodies were also positive. At first, she was treated with IV steroid pulses, followed by 25 milligrams a day prednisolone that was lowered to 5 milligrams a day, and she was also treated with hydroxychloroquine. She stopped slowly prednisolone in May 2009 when she was 19 years old and in clinical remission. During these last couple of years, she had recurrent genital herpes. So I'm going to start with you, Andrea. If this patient was being treated currently, 2022, would you have waited 3 years to try to stop the steroid dose? And what is the current thought on pros and cons of maintaining low-dose steroids?
Yes, I think that maybe if the case was happened in this year, probably the attempt to decrease and to stop the glucocorticoids could have been done a little bit earlier. The reason is that we have very clear data that also a low prednisone daily dosage, if taken for a long period of time, can contribute to the damage progression. And we know that the damage is a predictor of a bad disease outcomes. And so I think that if a patient's in a stable remission, a stable clinical remission, I think that after maybe one year and a half, an attempt to gradually tapering and then stop the glucocorticoids, I think that it is very reasonable.
And Sandra, do you find it easy to stop the steroids from the patient part? Do they fear to stop it? What is your current practice about it?
You know, these patients would hate steroids when they've been taking high-dose steroids for a long period of time. This is a young patient and juvenile, as a matter of fact. So the disease started, I believe, at 14 years old.
Yes.
And when you're 14 years old, you are young. You have so much in life. They wouldn't want to be taking steroids with all the side effects, especially the cosmetic side effects. And then on long term, for a 14-year-old, we know that in young people, and you give them steroids in children and adolescents, one of the things that really get concerned about is also the stunting of the growth. So there's a lot and irreversible changes, cosmetic changes, including striae, especially if you have chronic steroids. And this is of particularly concern in the young. So I would, at this point, if I saw this patient at this time, I wouldn't have waited 3 years to try to stop the steroids. So I would start this patient with a DMARD, especially with a steroid sparer. And of course, hydroxychloroquine is there. But I would be more aggressive, maybe in giving this patient start off with the manifestations, prominent arthritis. I would start with methotrexate.
Okay. Let's let's just see how it goes. So let's go back to the case.
And another.
Yes, Andrea. Yes, please.
If I can add, Raquel, other things that I think that another variable very important to consider in view of tapering and stopping glucocorticoids is the time to achieve remission. Shorter the time to achieve a remission, safer is the tapering and the stop the drugs, because a faster the shorter the time to achieve a remission, it means the disease is much is milder and probably is easier to control.
Yes. So if this patient was on clinical remission, on the next 2 or 3 months, you would taper it earlier than if she was on remission after 6 or 7 or 8 months.
I am much more confident.
Okay. So, and she remained in remission of drugs, only on hydroxychloroquine, for 3.5 years after that. But between January and June 2013, she had 3 flares. The first flare was non-infectious fever with polyarthritis. The second flare, recurrent polyarthritis and serositis. And the third flare, the one that we are seeing now, had fever, fatigue, cervical adenopathies, malar rash, and polyarthritis. She had been increasing and decreasing prednisolone to 25 milligrams a day and then gradually lowering between flares. Methotrexate now, it was tried but was not tolerated due to gastrointestinal symptoms. She had another genital herpes ulcer, and blood tests right now have moderate elevated CRP, low C3, pretty high titers of anti-DNA antibodies, and creatine kinase was 9,000. At this point, she is 22 years old. She has lupus for 8 years. She had previous serositis, low-grade proteinuria, and currently she has recurrent involvement with constitutional, skin, arthritis, and possible myositis, low complement, high titer DNA. She has been active for 6 months now, but she was previously on remission for about 6 years. And she is now on 20 prednisolone, hydroxychloroquine 300, a SLEDAI-2K is 12, and she has no damage accrual for now. So she has definitely a lupus flare. We'll need to treat her differently. But before discussing that, Andrea, do you think that these U1 RNP positive, we don't know the titers, okay, with myalgia and elevated CK, would you consider a mixed connective tissue disease in this patient? And do you think that the choice for the best treatments would be changed for that?
Really, Raquel, I do not think that this patient has a mixed connective tissue disease. You know that in the original description from the Sharp disease, it was written that the patient has not to have the anti-double-stranded DNA antibodies. Although later on the things has changed a little bit, and also the mild low levels of anti-double-stranded DNA has been accepted. I think that in this case, the serological features are clearly indicative of systemic lupus erythematosus. Of course, I think that the anti-U1 RNP can lead to a spectrum of manifestations, which include myositis, Raynaud's phenomenon, and maybe pulmonary hypertension, but within the feature of SLE in this case.
Do you agree, Sandra?
Absolutely. I would address this as lupus, and in any lupus patient, you look at what is the organ involvement. It's not so much the autoantibodies, but particularly the organ involvement. Now, one of the things that bothers me is this: the first time the patient had proteinuria, We know that
Yes.
the patient has symptomatic skin. I mean, this causes symptoms, and this would bother the patient. And arthritis and myositis would be bothering the patient, but they're not as bad for, in a general sense, in terms of treatment, as somebody with a kidney involvement, which can be quiescent in terms of no symptoms, but it is one that will impact really on long-term outcomes.
Yes.
So I would maybe symptomatically, when I say symptomatically, I would try this patient, of course. One of the things is address what are the manifestations that this patient, involvement of this patient in terms of organ involvement. So I can see the skin, I know the arthritis manifestations and the myositis, so musculoskeletal manifestations. They're bothering the patient. But I would sit down with her and talk to her and say, there is something going on in your kidneys. And I like a bit more information on that, because that is the one that will impact on long-term outcome. So I would address the kidneys and even suggest a kidney biopsy at this point.
Probably on the beginning of the presentation of the case, being a juvenile SLE, when she had that proteinuria, that would be really important to do it. We know that juvenile SLE with lupus, with the proteinuria, can have severe biopsies than the classical presentation from the adult one. But right now she doesn't have proteinuria, so let's take it as a safe place. So what would you consider, Sandra, the treatment for her now that she can take methotrexate? What would be the treatments that you consider for her right now?
Well, if this was a patient who was in our setting in a third world country, one of the things is that, okay, she has prominent musculoskeletal manifestations. I would treat her musculoskeletal manifestations. I would address it to that. And we have options for that. We have, if she cannot tolerate the oral methotrexate, we do have intramuscular or parenteral methotrexate. That can be one option, which is also inexpensive. The other one could be treat with leflunomide. So leflunomide does work well for this. And as one would treat arthritis, like rheumatoid arthritis. You know, we've been borrowing drugs from rheumatoid arthritis in terms of DMARDs, and we're using that in our patients with prominent musculoskeletal manifestations. So those would be the options for now. And if the patient was better off and financially better off, yes, I would really, really go for biologics, especially belimumab.
Okay. And Andrea, what do you think?
Yes,
we live in a different setting. Yes.
Of course, option which have been proposed by Sandra are all are very reasonable and very acceptable also here in Italy. But here we are a little bit more lucky than Sandra. And for example, for us is not easy to have belimumab. Belimumab in Italy, it costs much lower than also in other European countries. And so this is one of the reasons for which we have used it probably more than in other countries. And in patients like that, I think that it is particularly indicated the belimumab because the patients has a typical relapsing remitting profile. So frequent relapses. And this is, in my opinion, one of the main main predictive variable of the response to belimumab. The other one is the serology. She had a very high title of anti-double-stranded DNA antibodies and low C3. And so I think that even those biomarkers are among the predictors of response to belimumab. And so in this case, and in addition, the younger age, I think that also the fact that this younger lady, I think that another reason for which I think that it could be reasonable to use belimumab, which we know that is also very safe, and so it is an additional reason.
And it's the on-label biological that is now. We will have anifrolumab probably to use on the next times. Would you consider that? Would you be worried about the genital herpes? Would it change your choices?
For me or for Sandra?
I think for both of you, but since you were talking about biologicals, probably first you.
Okay.
I would still go for belimumab. Yes, Andrea?
Yes, I agree. I agree with Sandra, because in this case, as you mentioned, there is the problem of the herpes simplex, and we know that anifrolumab, since it reduced the interferon type 1, which is a protective cytokine for virus infection, I think that in this case, since we have both available, I think that in this particular case, probably belimumab is the best choice.
Perfect. Let's go on. And she actually was given IV belimumab monthly. And 4 months later, she only had 2 swollen joints. She had positive serology, and prednisolone was already being tapered. 6 years later, she was still on monthly belimumab with no clinical or serological activity, off steroids, on hydroxychloroquine. So it went well. And now, would you take belimumab off? How would you do that? Sandra, can you discuss about it?
Absolutely. I mean, we have not much choice. If this patient has been on belimumab, at least in our setting, one of the reason why belimumab is the best choice for now is not because it's the only one that's available, but it's had a long track record. You know, it's been studied in several patients already. You have a lot of studies. You have a lot of references that have reviewed its safety. We had phase 4 trials that looked at long-term safety, and it has established its safety profile. So it's fine to give it for several years if it can be afforded, if the patient can afford it. Now, I would give the question now, I will toss the question to Andrea on, would you taper it? Would you remove it at this point? In my setting, if you can no longer afford it, then take it out. And most of the time, you know, they take the belimumab is administered only for as long as they can afford the medication. What about in your setting, Andrea?
Sandra, it is a good question. What I think is that we have not to stop belimumab too early. We have all the time to evaluate very well the condition of the patients. But it is clear that if the remission is a stable remission over time, after a reasonable period of time, which depends on many things, including what I mentioned before, how faster was the achievement of remission. So after a reasonable period of time, I think that it is also reasonable to try to first to reduce the dosage or to prolong the interval, make a spacing to prolong the intervals among the infusion of the subcutaneous injection, depending on the route of the administration. And so I think that it is reasonable to do it, but I have to tell you very honestly that it happens to me also to stop hydroxychloroquine in patients with persistent remission. Because if a patient has a persistent remission, maybe better if the remission is not only clinical but also serological. I think that an attempt to stop all the drugs has to be done.
So you read my mind. I was going to ask you, she's still on 300 milligrams a day of hydroxychloroquine, which is probably the 5 milligrams kilo day for her. And she's on it for 14 years. If she's really taking them, we know that compliance is not exactly what is prescribed. So for another talk, probably. So it would sum up 1.5 kilograms of cumulative drug of hydroxychloroquine in her system. So what are the strategies that you use before taking it off completely, as you were saying? What are the strategies that you use to lower the dosage of the prescription to the least chronic cumulative side effects? Sandra, please.
I think this patient should be seen by an ophthalmologist.
Yes.
And they have the what they call as the ST optical coherence tomography.
Yes.
And that is one of the more sensitive tests to look for whether you are now on hydroxychloroquine, retinal toxicity, and definitely you have to stop the hydroxychloroquine at this point. So there's no point in continuing the hydroxychloroquine.
But if we notice this, and we are more and more noticing this on our patients, we are more aware of this every time. So if you notice this, probably 6 years ago, would you lower the hydroxychloroquine as you would do with other drugs? Or would you just stop from the 5 milligrams kilo a day to no hydroxychloroquine? Or how would you do? How would you say to the patient how many they are taking?
I don't think there's, unless Andrea would comment on this, I didn't see any study on tapering hydroxychloroquine.
Yes, I don't think there
are. Yeah, for practical reasons, our patients usually just come to us and say, are you taking your hydroxychloroquine? Of course, you have tests to find out whether they're really compliant to it. But they say, oh, I feel like I don't want to be taking too many drugs. So what they do is they take it every other day. And that's definitely much, much less than 5 milligrams per kilogram per day. So we're all with that. Just don't go beyond 5 milligrams per kilogram per day. But I don't see any reason for them to go down to 3 milligrams per kilogram per day if it makes them feel good.
Okay. It's your experience also, yeah. Andrea?
So, Andrea?
Yes, I agree, because you know that there is a debate among the experts on the fact that also 5 milligrams per day probably is a low dose, is a dose below what it is considered really the effective dose. So there is this debate. I personally try to keep the dosage up to 5 milligrams per day, just for the reason of the ophthalmological side effects. But in any case, there is this debate. There are some of our colleagues who thinks that the 5 milligram per day is milligram per kilogram per day is not enough. And so I agree with Sandra that tapering the dosage is not so effective and is not so reasonable. So after 15 years, it is clear that we have to think that the probability of develop an ophthalmologic side effect can increase. We know that after at this dosage that we are speaking at 10 years, the risk of developing a retinopathy is approximately 2%. But this increased progressively in the following decade, and so at 20 years is 20%. In any case, after 15 years, I have read that the risk is 4% per year. And so I think that we can also continue keeping into account that we have to closely monitoring or if the patient is in remission, as in this case, maybe we can also consider to stop it. Maybe we can, in this case, we could decide to continue belimumab and to stop hydroxychloroquine, for example.
Quite a little bit more expensive, but not for the toxic effects.
But of course, I think that we have to think to the safety and to yes, and to the health of our patients. And so I think that it could be reasonable. Maybe our payers are not so happy, but
Okay, I think this was a good discussion. So
may I
yes.
Ask
Of course.
regarding belimumab, because another question there is that if you would compromise on prolonging the intervals between your belimumab doses, would you prolong the intervals? Like instead of giving it every 4 weeks, can you give it every 2 months?
But with the subacute every 2 weeks, for example, after 10 days and then after 2 weeks. Up to now, I didn't move behind this spacing.
Okay. Good discussion. I think we learned a lot from your practical clinical experience. So let's move to the second case. And this is different. He's a man with lupus, a 20-year-old man from the Philippines. He was diagnosed with SLE, first presented as a class 4 crescentic lupus nephritis, pretty severe. He was starting on cyclophosphamide, the NIH protocol, and methylpred boluses, followed by prednisolone, 40 milligrams a day. After the second cyclophosphamide infusion, probably 6 weeks after the beginning of the treatment, he developed fever, malaise, painful swelling of the elbow, and jaundice. He was admitted, and on examination, jaundice was obviously clear, and an elbow red, really warm and swollen monoarthritis were the most preeminent features. So I'm going to start with you, Andrea. We are both from Southern Europe, so we have different realities. What do you think about this crisis? Is it a flare? Would you think of other things? What is the most probable diagnosis? How would you prioritize the workup? Please feel free.
Yes, I think that she was just treated with the cyclophosphamide, which is one of the most effective and strong approach to SLE. And so I do not think that this is a disease flare. I think that it is a disease complication. And so since it is monoarthritis, with the characteristic that you have described, my first hypothesis is an infection, is a septic arthritis, and so the first maneuver is to make the synovial fluid aspiration and to the culture of the synovial fluid.
Of course, and what would you expect would be the bug behind it?
Which question?
What do you expect to be? What kind of infection would you expect to have in Italy with this patient?
But in Italy, the first things is for example, a gram-positive bacterium, for example, Streptococcus. Although it is true that he was treated with the cyclophosphamide, and so it is also the possibility that the microbe is an opportunistic infection.
Of course.
Although usually the opportunistic infections are less severe in their presentation, are more subacute than in this case, the clinical picture is really very acute. And so I am expecting a bacterium.
A bacteria. So Sandra, this is your patient. So can you comment on all this and your reality with infection in lupus?
Right. You know, in any lupus patient who is immunocompromised, and she's immunocompromised because of the cyclophosphamide and the high dose steroids. So that's a given. So immunocompromised patients in general, when they have an infection, so the most common is still the common infections.
Mm-hmm.
So it doesn't spare them from the common infections. So I definitely agree with Andrea that you have to think first of your staph, strep, and the opportunistic infections that can occur in any immunocompromised patient. But in my setting, one of the things we still think of is, oops, maybe this is, one of the very common, because it's so endemic in our place of the world, in Southeast Asia, you'll have to think of tuberculosis. Now, the other point here in terms of clinical approach to these patients is that one of the caveats, of course, in any patient who comes in with an infection, with arthritis, one of the very simple, it's almost like, you're teaching medical students. When you have an acute arthritis in a patient with lupus, if it is distinguished, is it acute monoarthritis or acute polyarthritis? Polyarthritis is more for lupus flare, and monoarthritis, definitely an infection.
Yes. And do you think that this jaundice has anything to do with the treatment? And isn't it too acute to be... It's strange to have a monoarthritis with jaundice, isn't it? So do you think that the treatment has anything to do with it? What's your experience about it, Sandra?
Oh, strange indeed. You have monoarthritis. This is very, very prominent in this patient. Then you have jaundice. So one of the things you investigate is jaundice is something that happens in the liver. So you look for a liver problem. So you'll have to investigate this patient and look at what's happening there. Is this... it's rare to have hepatitis secondary to cyclophosphamide.
Yes. Mm-hmm.
So it's not usual. Yes.
Yeah. Sandra.
Andrea?
No, Sandra, maybe you are much more experienced than me with the tuberculosis, but tuberculosis is not uncommon in the liver, in the biliary
System.
apparatus systems.
Mm-hmm.
Is it true?
It depends on where you are, because in our place part of the world, when you have tuberculosis, especially in SLE, we have studies on that show that TB in SLE, in a series of tuberculosis in SLE, there's a high incidence of extra pulmonary tuberculosis, and they can have normal chest X-rays. So liver is definitely one of them. And especially if you have hepatic calcifications, that's one of my mentors in gastroenterology has always taught me, if an ultrasound you find calcifications in the liver, always think of tuberculosis. Mm-hmm. So it's a simple workup, but you'll have to keep this in mind.
So you just want to confirm it because you already have it on your mind that this patient has probably tuberculosis. So, and the workup, yes, revealed hepatic calcifications on abdominal ultrasound, normal chest X-ray, as you said. The synovial fluid was aspirated from the elbow joint, and urine specimens were positive for acid-fast bacilli. So it's probably really tuberculosis, and it grew on cultures. And the patient was started with anti-TB therapy. So now we have two questions to both of you, because there are different settings, as we have discussed. Sandra, do you do any screening for tuberculosis before starting high-dose steroids or cyclophosphamide? Do you have time for that? Do you have policies for that? Is it worth on an endemic country for TB?
Oh, yes, absolutely. Well, simple screening. It's no fuss screening. Just get a chest X-ray. Of course, your clinical history, exposure, tuberculin skin test is easy to do, or an interferon gamma release assay, or an IGRA test. So those are the ways by which we screen them, but before giving them steroids. And these are simple tests. And of course, we start any patient who comes to us newly diagnosed with lupus. Before we start them on steroids, we make sure that they have a normal chest X-ray, and the clinical manifestations also have a good physical examination.
Okay. And if the TB is positive or latent TB, would you do prophylactic therapy before starting steroids?
If it was, yes.
Okay.
Not just before starting steroids. If you need to start your steroids, go ahead. And if this is latent tuberculosis, so in other words, you have a positive tuberculin skin test or IGRA, and give them prophylactic. So give them therapy for latent tuberculosis. But it doesn't mean to say that you have to withhold your steroids because this patient is active lupus. Yeah.
Yes. And Andrea, what in your context, would you screen all the patients before giving high-dose steroids?
But honestly, no, Raquel. I do not test the tuberculosis. I do not perform tuberculosis tests before using glucocorticoids or also immune suppressant. We only used to screen patients with rheumatoid arthritis or spondyloarthritis before starting the anti-tumor necrosis factor alpha. But I agree in general that I think that it could be a good idea, especially in patients with severe manifestations. So where you think that you have to use high dosage, maybe for a long period of time, especially in those patients with severe manifestations, maybe it could be appropriate to make the tuberculosis test before starting treatment or immediately after starting the treatment, of course, if you cannot delay it.
I guess that just according to if you have low incidence tuberculosis, probably.
Yes, of course, in Italy there is a low incidence. But in any case, and the reason is that do you know that, for example, for a long time, we have taken care of the cardiovascular risk in our patients. Mm-hmm. And I think that the time has come to also to take care of the infective risk, because we know that it exists. As probably, we have recently performed a study on mortality in our region, which is the Venetian region. The study was carried out on 5 million of inhabitants and exactly on 4,000 and maybe 200 or 300 SLE patients. And we found that the most common cause of death were cardiovascular disease and cancer. And in infections were less than, the infection frequency was less than expected, also looking to other studies. It has to be pointed out that this study was carried out in the last 8 years, from 2012 and 2020. So very recent years. And so, of course, we cannot make the comparison with the past because this is the data that we had. The administrative registry that we look was started in 2012. And so we had data only since then. But I think that this mirrors the advance that we have done in the field of the prevention of infection disease with the vaccination, with the microbiological test, with the new antibiotics. And so I think that is the avenue that we have to follow to take care of infection in our patients.
We actually should discuss an algorithm and a risk score for lupus patient. That would be perfect. So, and finally with this patient, he didn't stop having lupus nephritis, pretty heavy and active lupus nephritis. How would you treat this lupus nephritis after this generalized tuberculosis, Sandra?
Before we go into that treatment, one of the challenges that we see a lot of tuberculosis in our lupus patients. One of the challenges we have is you can see that these patients is jaundice, and there is a liver problem. And we know that there are, you mentioned that these patients also had hepatic calcification. So we presume that this patient has disseminated tuberculosis, including the liver.
Yes.
So remember, you are giving also, as part of your anti-TB regimen, a hepatotoxic drug.
Toxicity.
So this is the dilemma that you face with these patients. And of course, the priority is to treat the infection. So you just have to closely monitor, work with the infectious disease specialists. So they're the ones who work with us. This is my patient, our patient. So we work closely with the infectious disease specialists, of course, give them the headache on determining this. One of the other things that also we see among our patients with chronic infections like tuberculosis is that this seems like when they get the infection, they seem to have some kind of a flare. So
Yes.
the infection, if you treat the infection, then somehow the flare, the disease, lupus disease activity gets a bit better. I'm not sure if you notice this also. For some reason, it's probably the infection is a form of stress that induces disease flare in these patients. So I wouldn't be surprised if this patient had, actually, this patient we were able to treat, go back to cyclophosphamide regimen after adequately treating the drug-susceptible TB. So again, I just like to emphasize the drug-susceptible TB because it's going to be a different problem if this patient has multi-drug resistant tuberculosis, as you would have, which is why even the prophylaxis for TB is conflicting and controversial because given a scenario, you have a normal chest x-ray, but your patient has disseminated extrapulmonary tuberculosis. So give this patient prophylaxis, INH alone, or just a dual drug. So what do you get? You get resistant tuberculosis. That's another scenario that you would like to avoid in these patients. And there's an increasing incidence now of multi-drug resistant tuberculosis. So it's still the jury is still out on whether we give prophylaxis to these patients or not. So, well, the good news is that if you have drug-susceptible TB, it is very treatable and curable. And again, as I mentioned, it's not surprising if even the lupus gets better once you treat the tuberculosis.
Perfect. Andrea, in your setting, if this patient was living in Italy, coming from Philippines, and had this generalized TB with active lupus nephritis, would you give him for lupus nephritis after treating tuberculosis? Would you still give him cyclophosphamide, or would you change it for another strategy?
Raquel, yeah, you have to know that our hospital here in Padova has been built near to the Sant'Antonio Church. Do you know? So, and one of the reasons was this one, in order to be able to take care of patients with a desperate condition. And this is a patient with a desperate condition. Now, I agree with Sandra that the first thing is to treat tuberculosis, and we have to a little bit to postpone the treatment of lupus. Of course, we can use glucocorticoids and not to too much high dosage. Maybe something that could be considered in the meantime here in Italy, where we are very rich not very rich, but in any case, we are. And is, for example, the IVIG. The IVIG could be an option because we know that it has been shown that there are some data on their efficacy also in the lupus nephritis. Or another things that could be, but in any case, after the start of the tuberculosis treatment could be the plasmapheresis. That is another approach we can in some way to block the disease, not to cure, but to block, and so to give us the possibility to treat the patients for tuberculosis in order then to restart the treatment with the immune suppressants.
As a bridge therapy.
as a bridge therapy. Yes.
Yes. Would you consider rituximab for this patient? It is one of the immunosuppressives that has the lowest TB reactivation rate. So
yes, and also belimumab.
Yes, for lupus nephritis. Yes.
For lupus nephritis, belimumab can also be an option, not starting since the beginning, because I agree with Sandra that the first thing is to try to control the tuberculosis first. But we can little bit later on to restart also the treatment for lupus.
Yes. So I think we did have fun discussing these cases, two different realities. Thank you so much, Sandra and Andrea. Thank you so much for joining me today and sharing your insights. To our listeners, we hope these discussions have helped you gain more than an understanding of lupus. Do send us feedback on cases you would like us to discuss in the future. In the next episode, Andrea and Sandra will return to discuss another case study of polyarthritis in a young woman. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next month.